You've got 10 seconds. Diagnose these images or repeat medical school. Look, if you see a coffee bean on your boards, it's not break time. It's a volvulus and someone's about to lose their colon. Hey, I'm Dr. Lucas, former medical school professor, full-time board prep educator, and DO, which stands for definitely overwhelmed. In this video, I'm walking you through every high-yield abdominal image guaranteed to show up on COMLEX and USMLE. I'll also explain the pathophys and management of each one so you finally understand this stuff, hopefully. So if you're tired of squinting at radiology images and hoping for divine intervention, this video's for you. Chronic pancreatitis. Repeated episodes of pancreatic inflammation cause irreversible fibrosis with loss of exocrine and endocrine function. In English, digestive juices and insulin pump not work good. It's most commonly from chronic alcohol abuse. Just anterior to the aorta, you'll see this asymmetric, I don't even know how to describe this. It kind of looks like born on the no, it just looks like a turd, let's be honest. But this structure here, you'll see some bright white spots in it. Remember, white is dense. Dense would be bone, or it could be contrast if we're using that. Kind of looks like we are using some contrast because you see a lot of white everywhere. Opacities in this structure, these bright white densities, is very specific for chronic pancreatitis. So this structure, this organ is the pancreas. Remember, it's just anterior to the aorta. It's still retroperitoneal. So even though it looks like you're in about the middle of the abdomen, this is still a retroperitoneal structure. Bright white patches means we're looking at calcifications. Calcifications in the pancreas means chronic pancreatitis. Management depends on the cause, but if it's due to alcohol abuse, stop the alcohol. If pancreatic insufficiency is also present, then you're going to want to give enzyme replacement so their poops aren't as greasy as a Papa John's pizza. This is just a fluoroscopic image to show you the difference between Haustra and Valvulae Conniventes. So if you take a look here, this is a very clean, very clear image. You can see the Haustra, the little lines that separate them, don't go all the way across. So if you look at this one, it goes maybe 3/4 of the way, maybe 4/5, but it doesn't go all the way across. Same here, you can see it goes most of the way, but not all the way. Now, this is not as clear of an image since this is just a regular abdominal x-ray, but if you look very closely, you will see that these lines do tend to go a bit further, and you'll see, again, very closely that they do go all the way across the wall of the intestine. All the way across means you're looking at Valvulae Conniventes. Valvulae Conniventes are part of the small intestine, so this helps you identify that you're looking at small intestine. Haustra are in large intestine. Cholecystitis. Your gallbladder is the purse that you store your bile in. When a gallstone lodges in the cystic duct, bile gets trapped, pressure builds, and the wall becomes inflamed, ischemic, and possibly infected. That all describes acute cholecystitis. Here we have a positive gallbladder sign. Love that. Thank you, ultrasonographer. Get used to looking at ultrasounds of the gallbladder. They come up a lot on boards, especially level 2. You need to be able to recognize this empty cavity here. So there's really nothing in the cavity of the gallbladder. And then it forms kind of the neck where it would empty out into the cystic duct right here. It's a bit grayer over here, but lighter, and then a little darker up top. So darker, probably empty. This lighter gray, this might actually be biliary sludge. It's not quite a stone. It's not quite normal bile fluid. It's somewhere in between, just a little more dense. And then it looks like you've got a stone right here, this brighter white structure. And you can see kind of overlaps here. This all this asymmetric area. Doesn't quite look like it's obstructing. It's just in the gallbladder at this point. What's really important to look for in these ultrasounds would be the actual wall of the gallbladder itself. This is where they like to test you, and because there are really important features that you need to look for. For example, how thick is the gallbladder wall? And so just take a look at the diameter of this wall here. Say, does it look particularly thick compared to the rest of it? Take a look at normal gallbladder ultrasounds as well to compare. And then what really stands out here is probably this layering that you see, and you see it very well right over here. This layering is our pericholecystic fluid, our inflammation of the gallbladder wall. And that's all telling us that this patient might have cholecystitis, just inflammation of the gallbladder over time, probably from these stones. Management is almost always a laparoscopic cholecystectomy within 72 hours. And don't forget to add antibiotics for gram-negative and anaerobe coverage. Intussusception is one of the hardest words to spell in this entire video, but basically it's when one segment of bowel folds into the adjacent segment like a collapsible telescope, literally just collapses in. Basically, you have a loop of bowel within another loop of bowel. It's bowel inception. So this compresses the mesenteric vessels, causing venous congestion, ischemia, and eventually necrosis if untreated. It's most common in kids between 6 months and 3 years old. Knowing the ages, 6 months to 3 years, can really help you distinguish this from other conditions that affect affecting the GI tract in pediatric patients. Moving on. Management is almost always an air or contrast enema, which is pretty cool, but essentially, by putting farts into reverse, you can blow the bowel back out. It's diagnostic and therapeutic. Kidney stones form when urine becomes super saturated with stuff like calcium oxalate, uric acid, struvite, or cystine. As the stone travels down the ureter, it causes obstruction, hydronephrosis, and the kind of pain that makes Navy SEALs cry. What sticks out here would probably be if you look laterally on both sides, you'll see these opacities bilaterally, which is pretty abnormal. Bilateral opacities in these large gray structures, and you see those large gray structures on both sides. Well, that'll be the kidneys. So we're looking at both kidneys here, and they got these bright white patches in each one. Bright white means very dense could mean bone, or in this case, calcification. Here we've got a very zoomed in image of an abdominal x-ray. Orient yourself with the spine here on the left side of the image. If it's flipped, then this would be the left side of the patient. And we're really zoomed in here on this structure, this opacity. It's very irregular looking, irregular contour. If you think about it, it kind of looks like a pair of antlers from a deer. And that's precisely why it's called a stag horn calculus. Stag meaning male deer. Horn looks like horns of a deer, and calculus meaning a stone. This is a type of kidney stone. Specifically, staghorn is one name for it. Struvite is another. Ammonium magnesium phosphate would be the third name for it. You might see this on an x-ray if it's large enough. These stones do get very large and they get lodged in the kidneys themselves. They might not even make it into the ureters. They just get stuck in the kidneys and they can show up like this on x-ray just because they're so big, and they are dense enough to show up as well, just like the calcium. And just like my ex told me before she left, size does matter. For small stones, think like less than 5 millimeters, treat with hydration, NSAIDs, and a kiss on the forehead. Fluids can help dissolve the stones. NSAIDs and a little peck on the forehead makes the pain go away. For larger stones or persistent obstruction, you can go directly to lithotripsy. And typically that's just ultrasound shockwaves that are used to break up the stones. It's kind of like weaponized echolocation. It's cool stuff. You can also use alpha blockers like tamsulosin, which can help relax the ureter to help pass the stone. The appendix gets obstructed usually by a fecalith, like hardened stool, but sometimes lymphoid hyperplasia or even a tumor can obstruct the appendix and cause appendicitis, and I've seen all three of those on practice questions. Obstruction causes increased intraluminal pressure, venous congestion, bacterial overgrowth, and ischemia, and eventually perforation. What stands out to us in the abdominal contents? Well, it'll be this bright little white spot right here. This density is called an appendiculith. So this patient probably came in with middle abdominal pain radiating to the right lower quadrant. This is classic for appendicitis. It could be caused just because this little thing got stuck in the appendix. Management depends on if you've done any imaging and how sure you are about the diagnosis. If you're as confident as the average lifted F-150 owner with truck nuts, then you can just skip the imaging and go straight to surgery. Diverticula are outpouchings of colonic mucosa that herniate through weak points in the muscle wall. It's like a bunch of little aneurysms. It's like a bunch of little aneurysms that happen in the intestinal wall. When a diverticulum gets obstructed with stool, it becomes inflamed and infected. That's diverticulitis. If you walk yourself anteriorly here towards the top of the image, you'll see some calcifications in here. This could be some atherosclerosis of some vessels, but if you keep going, you'll see a bunch of little dark spots, a little speckling, lucency throughout a lot of what would be the intestines, kind of all over the place. These small little dark patches are diverticulum. So we're looking at diverticulosis, possibly even diverticulitis. Management includes bowel rest, clear liquids, and antibiotics covering gram-negatives and anaerobes yet again. Once the intestines aren't mad anymore, you should get a colonoscopy about 6 to 8 weeks later to rule out colon cancer and possibly IBD, because they do present pretty similarly. Just make sure you do not get a colonoscopy during the acute diverticulitis episode, because you could actually perforate the patient's bowel. Now, if you're thinking, this is helpful, but I need a way to review this repeatedly without watching the whole video all over again, I got you. Join my Skool community. It's totally free and you'll get a ton of free stuff, including this entire video transcribed into closed deletion Anki cards, as well as monthly office hours with real board tutors like me, a community where DO and MD physicians answer all of your questions every day. No credit card required, just support. Link in the description. All right, back to the reading room. If the duodenum never forms a hole in the middle during development, you end up with duodenal atresia, which creates a complete bowel obstruction. It's strongly associated with Down syndrome, so make sure you've got that in an Anki card. Here we've got two large lucent areas towards the upper abdomen here. This is classic for your double bubble sign. So there's an obstruction in the duodenum. That's what causes air to get stuck behind that obstruction. So you see it gets stuck here. That's this bubble. And then the second bubble is the stomach. The pyloric sphincter is just going to cause this separation here instead of just being one big bubble, kind of like a roadblock that's just in the way, showing you two bubbles. This needs surgical repair with, brace for it, duodenostomy. 10 syllables. That's illegal. Jejunal atresia is an obstruction a little further down. Here we've got 3 large lucent spaces, 1, 2, and 3. Looks very similar to the double bubble sign. Oddly enough, we call this one the triple bubble. It's just the next segment in the intestine that's now been obstructed, and air gets stuck at that point and just kind of backs up into everything else. Management is the same as duodenal atresia. It's just surgical repair, except I couldn't find a cool name for this one. So make sure you look for double bubble versus triple bubble. Bowel obstruction is what happens when the pipes get clogged. It's most commonly due to adhesions, hernias, tumors, intussusception, anything. Now, what really should jump out at you would be all of this lucency, all this dark area in the image, and what looks to be like we're looking at intestines, but there's a lot of dark spots, and then there's a lot of bright white at the very bottom. And then if you look between the two, you'll see this clear line demarcating the border between the dark spots, the lucency, and the white spots, the opacity. This is called an air fluid level. Remember, air shows up dark on X-ray, and then fluid is bright white. Somebody who has air fluid levels, you'll see probably multiple of these. So here's one right here, just sharp demarcation, fluid down here, air up here. Here's another one, air up here, fluid below that. Here's the other one that we talked about initially, air, fluid. If you see multiple of those on an abdominal x-ray, you're looking at a bowel obstruction. And this one has a bonus for you. If you notice this large opaque structure in the background, it looks to be based on the spine. Always orient yourself with the spine. And then we know for the most part, we're looking at flipped x-rays. For example, they put the R on this side to tell you this is the patient's right side. This is the patient's left side. What large opaque structure is in the right upper quadrant? Well, it's probably the liver. Now, the liver looks a little strange because you're probably not used to seeing a lot of space above it. You're not used to seeing this. And then what is this little structure up here? Again, dark areas mean it's air. You're not supposed to have much air above the liver, right? And then this bright white structure up here, that is the heart. This is the cardiac silhouette. So why is there all this space? That's because this air is from a pneumoperitoneum. We're looking at a bunch of air that's just floating around in the peritoneal cavity. It's not in the intestines, it's outside of the intestines. So what might have happened here is with our bowel obstruction, it could have perforated the bowel, and now it might be leaking air into the peritoneal cavity, pressing the diaphragm upward, pushing the liver away from it. You can usually see this on chest x-rays too. They usually capture the diaphragm, and just underneath the diaphragm, always, always, always look for air underneath the diaphragms. Management's pretty simple. It's just no food or water by mouth, nasogastric tube decompression, and IV fluids. If it doesn't resolve, or if there are signs of ischemia or perforation, then you definitely need to go to surgery. Remember, kids, Peritonitis is bad. In volvulus, the bowel twists on itself, causing obstruction and possibly vascular compromise. The two main types are sigmoid volvulus, which is the most common, and then cecal volvulus. Sigmoid volvulus typically happens in elderly patients, and cecal volvulus happens in newborns and infants. You'll see a lot of lucency right in the middle of this image over the lumbar spine and over the sacrum. And right around that, you can see what appears to be relatively normal intestine. If you were to kind of trace this, let's zoom in. You can kind of trace this with your cursor all the way around here. Kind of looks like a big coffee bean or even just a kidney. And so you might be thinking, okay, this is probably some kind of volvulus. Now, the question is, what type of volvulus? Cecal volvulus tends to have this big coffee bean pointing towards the left upper quadrant. That would be towards this direction up here. Whereas sigmoid volvulus tends to have that coffee bean shape pointed towards the right upper quadrant. That's not always true, but that tends to be how they show it on boards, if they're going to show you this. Here's another abdominal x-ray with our coffee bean, very, very clear coffee bean sign here. This would be our sigmoid volvulus. So here's our spine just to orient ourselves. We've got the innominates over here. This one actually has a bonus. You got this bright white structure down here. This is actually a femur arthroplasty. This is probably a hemiarthroplasty because you don't see the acetabulum being replaced either. It's just the femoral head and beyond. And you can actually see, if you look really closely here, you'll see this fine white line. That's the patient's skin. You can kind of see like how bowed out their abdomen, their abdominal wall is from this massive, massive sigmoid volvulus. And again, it kind of forms this crease right in the middle because you got to imagine, just if you ever try to fold a balloon animal, make a dog out of a balloon, when you fold it, it kind of pinches in the middle and it sort of looks just like this when it folds on itself. And that's exactly what's happening to the intestine. Once it gets big enough, it gets caught on itself and it spins and forms that center crease. Management for sigmoid volvulus is colonoscopic decompression. You just stick a scope up there and untwist it. Cecal volvulus usually requires surgery right away, either cecopexy or right hemicolectomy. Toxic. It's what you call your ex, and what you call your colon when it's getting a little too zesty. This is what Britney Spears was trying to warn us about 2 decades ago. God, I'm old. Toxic megacolon is due to severe colonic inflammation that results in loss of muscular tone. If your colon can't constrict, it starts to dilate, and it can get really big.
That's what she said.
Thanks, Steve. It's usually due to irritable bowel disease, specifically ulcerative colitis, but it's also commonly due to C. diff. On x-ray, look for a dilated transverse colon with loss of Haustra, and pay attention to the stem to see if they give you a history of IBD or just a nasty GI infection. They usually also have severe abdominal pain, fever, tachycardia, and hypotension. They're usually just pretty unstable. This is a surgical emergency. Start with IV fluids, broad spectrum antibiotics, and make sure you stop all anti-motility agents. Remember, the problem is that the colon can't move, and it just keeps getting bigger and bigger. You want the colon to move. If medical management fails or there's perforation, you're going to colectomy. Speaking of ulcerative colitis, over time, that chronic inflammation causes the colon to lose its Haustra and become smooth and featureless, like a lead pipe. It usually indicates chronic and severe disease that's associated with increased risk of colorectal cancer. So how can we tell the difference between this and toxic megacolon? It depends if Britney Spears is playing in the background or not. So both can show loss of Haustra, but the key differences are in the colon diameter and the patient's vitals. Lead pipe colon is usually normal sized, and since this is a chronic process, they usually have stable vitals. Toxic megacolon can be huge and present with unstable vitals. They're generally a much sicker patient. The treatment for IBD is heavily tested, so I'm going to give you the full arsenal here. For mild disease, start with the aminosalicylates like mesalamine, abbreviated 5-ASA, or sulfasalazine. They basically just reduce the inflammation in the colon. Aminosalicylates are pretty similar to acetylsalicylate, which is just aspirin. Aspirin's an NSAID, so you can think of aminosalicylates like aspirin for your tummy. They're not technically NSAIDs though, but they are pretty similar. Traditional NSAIDs can actually worsen IBD over time, so try to avoid their use in patients with IBD. For moderate to severe flares, you can start adding steroids, but you just can't stay on these long term. So in steroid-dependent patients or people that just keep having flares, you should use the immunosuppressants like azathioprine or 6-mercaptopurine to maintain remission. Beyond that, you can escalate to biologics like infliximab or adalimumab. These block TNF-alpha and are just basically the big guns for UC. These patients also need surveillance colonoscopy every 1 to 2 years to screen for cancer. The colonoscopies usually start 8 years after diagnosis, and they are very heavily tested, so make sure you grab some cards on that. Since we're talking about IBD, let's get into Crohn's. Crohn's causes transmural inflammation, which is full thickness inflammation through all layers of the bowel wall. That leads to the bowel wall being replaced by scar tissue, which narrows the lumen over time, forming strictures. This appears to be a fluoroscopic image of the abdomen. You can see the pelvis here, the innominates, probably the femoral head. So we're using contrast, which is why we have this bright white over the intestines. And then you have this smooth, really thin segment that travels quite a ways here throughout this image. This is iconic for the string sign that you might see with a Crohn's disease. If the strictures are symptomatic, then treatment options include strictureplasty or resection. But on exams, treatment questions tend to be just about managing the Crohn's overall. And medical management for Crohn's is very similar to UC, except the aminosalicylates are less effective. Hirschsprung is a congenital absence of ganglion cells in the distal colon, usually the rectosigmoid region. Without the ganglion cells, the affected segment just cannot relax. It's kind of like med students, constipated, both emotionally and physically. Here, and you can see what looks to be the colon descending down in the sigmoid colon, and then the rectum down here. What you'll probably notice is that you've got this big, thick colon, the ascending transverse kind of disappears in the middle here. That might just be artifact. And then it's descending down, and you see it starts to get a little narrow right here towards the terminal descending colon into the sigmoid colon, and then really narrow here in the rectum. It almost kind of looks like a corkscrew right around here. Treatment is just surgical resection of the aganglionic segment. Aortic calcification happens when calcium deposits build up in the aortic wall. Over time, the aorta becomes stiff and less compliant, which increases the risk of aneurysm formation. We're looking at posterior aspect of the patient over here, and we see something a little strange just anterior to that posterior structure. Just anterior to the spine, we see this bright white ring surrounding less bright gray substance. And whenever we're thinking bright white, we should be thinking something is very dense there. The most dense thing we have would be bone naturally, and that's why the vertebrae is so bright here. And so we have to think, okay, what structure is directly anterior to the vertebrae? That would be the aorta. And so when you see this bright white around the edge of the aorta, you know you're looking at aortic calcification. This is very common to see in imaging, especially on boards. So make sure you recognize this. Do your Anki on this one. Aortic calcification is a marker of significant atherosclerotic disease, and it also increases the risk of abdominal aortic aneurysm, AAA. Not to be confused with AA, which is where I'll be going right after this recording. For AAAs less than 5.5 centimeters, image it every 6 to 12 months and treat it with lifestyle management. For AAAs over 5.5 centimeters or rapidly expanding, that needs to be surgically repaired, and you can do that open or endovascular. Make sure to memorize this. A rapidly expanding AAA is defined as expansion that's greater than 0.5 centimeters in 6 months. We made it. The best way to make sure the contents of this video French kiss your hippocampus is to grab some flashcards on it. If you want the high yield points from the video transcribed into Anki cards for you, join my Skool community. You'll get our practice test with short video explanations for every question and our study plan video. And if you're serious about passing and want expert help, who, me? Yeah, book a one-on-one strategy call with one of our tutoring consultants. They'll review your full test history, map out your timeline, identify exactly where you're losing points, and show you how we help students pass when nothing has worked before. All links are in the description. Now, get back to studying. These images aren't going to memorize themselves. You've got this.